Sweden as less than most haven't. Of course, I think I'm only about 1% of breast cancer cases are seen in men, and so the rates will be much lower in these cohorts. So it may be difficult to do that analysis, but to the best of my knowledge, no, there hasn't been that study. But even if you but think more broadly about the issues of long-term consequences of prolactin and go beyond breast cancer, I think there is a reasonable concern about osteoporosis risk and bone fractures that will be, which will affect both men and women. But yeah, in direct answer to your question, I don't believe there's been anyone with that. A similar study hasn't been performed in there.
Another question from Dr. Emmanuel Mayo is saying, I have a female patient with a raised prolactin of almost 4,000, tried various new antipsychotics, ABC drugs, but with various side effects reported by the patient. Currently in olanzapine, which appears to be the only antipsychotic with limited side effects that she feels able to tolerate despite the elevated prolactin levels. She deemed to have capacity to make the decision following discussion with the psychiatrist and the pharmacist. Do you have any suggestions about what else can be done?
Yeah, I mean, it sounds like you've done an awful lot to try and address this issue, and sometimes there's an unfortunate, we find ourselves in unfortunate scenarios where we have basically experienced a side effects and there's nothing much we can do about it. And I guess, a very common scenario to find ourselves in that is with clozapine, where we feel that clozapine is the only option for one individual, and we essentially tolerate the side effects, or we try and address them as much as possible, but we accept that there are going to be side effects which we address in order to get that clinical benefit. And so I think ultimately we can try our best. I mean, I'm sure you've tried this already. If the partial agonists aren't being tolerated, dose partial agonists as an augmentation strategy might be an option. I'm sure you've tried that already and tolerated. There is some evidence of using dopamine agonists in rare with endocrine input, and we do talk about this in the guidelines book. But bearing in mind that we think that dopamine agonism is pro-psychotic, and you have to be relatively brave, I would argue, to do that in someone with a psychotic illness. So well done for giving it a go. But sometimes we tolerate, even if you have discussed it with your patient and you go, look, we've tried everything and this is where we're at. And I'm afraid this is, if you're accepting of it, we're going to have to continue with it.
Question from Dr. David Bhattacharya. He's asking, in the past, Cymatic was available to healthcare professionals only in the UK. Is it available in other countries too?
Yeah. So we started off with, when we did a soft launch, a beta test about 6 months ago with a few NHS trusts in London, through word of mouth essentially, just to make sure that it was working well before we published the paper and left it out. This is now, we've changed the login, what's necessary to log in now, and anyone with an email address, doesn't even have to be a healthcare professional, you just need an email address to sign up, and that's it, and your name, and you will have access. So it is an international tool with international drugs. So not all drugs will be available everywhere. So there are 32 antipsychotics, I think there are 37 antidepressants, and some will be a bit alien to you. You will get, for example, in the UK, we don't have brexpiprazole, we don't have ziprasidone, for example, and but it will be but those do exist in other countries. So it is designed for international use, and everyone can use it.
I have a question here from Dr. Loriana Masticura. She's a consultant down in Syrian borders. It's quite a long question, so she's saying, thank you very much, Dr. Pillinger, for your engaging and indeed very informative presentation. Though there is clear evidence that clozapine is effective in treatment-resistant psychosis in adolescents, in my experience, there's considerable reluctance in prescribing it, particularly in young patients. This is possibly, at least in part, due to the greater risk that adults will side effects. As a result, their condition becomes chronic, and we often see a decline in their general level of functioning and quality of life at a very young age. I wonder what your experience and thoughts are in relation to this.
Yeah, so I mean, I've spent a lot of my psychiatric career giving people clozapine, and I'm very pro clozapine when it's to be used appropriately. I'm also very much a proponent of using appropriate treatment early in the sort of principle of time is brain, which I think is what you're sort of alluding to there in your comments and question. There's an issue in South London and the Maudsley of not appropriately giving people treatment-resistant schizophrenia clozapine in a timely manner. Not only in the adult population as well as the pediatric population. And we, as a consequence, are starting up our own specialist clinics to address this. So I worked for the adult version of this, looking to find people with treatment-resistant schizophrenia in the community and start community titrations. But I have a colleague, actually, it's Maria Roldacki, who I did that, doing that network meta-analysis, looking at metabolic and broader physiological side effects of antipsychotics in children, who's helping to set up a specific treatment-resistant psychosis clinic for children and adolescents to facilitate access to clozapine, because I think it's not just clozapine. I think my experience, and caveat here is I'm not a child and adolescent psychiatrist, but my limited experience of working in CAMS has been that there is, I think reasonably so, a reluctance or a bit more reticence to use antipsychotics, and maybe to use antipsychotics as a therapeutic dose. And I think having a specialist service to address that can be helpful, especially when it comes to a drug like clozapine, which does have, I think some clinicians can be a bit wary of, especially in the paediatric population. But it is an issue, I agree.
Another question, Dr. Starkington saying, I think he's in Leicester. So Toby, is there any major advantage of checking the monomeric form that macrolactinemia, sometimes pathologists argue?
Yeah, I don't tend to look for it. I don't tend to ask for it myself. I just look at the number, and if it's raised, then then I do something about it. But yeah, so I wouldn't get too bogged down with that person.
Question from Dr. Zain Alabasi's question is, a consultant in West London, how effective is aripiprazole for negative symptoms?
Depends which data you read. So yeah, there's an evidence base. I mean, the interesting, how long have we got? The interesting thing with negative symptoms and looking at the data to support it is that so Stefan Leut's 2019 Lancet meta-analysis, network meta-analysis, looked at ranked treatments based on how effective they are for total symptoms, positive symptoms, negative symptoms, cognitive symptoms. And for negative symptoms, there was a clear sort of hierarchy of treatments, and actually amisulpride came out very well in that treatment and alongside functional agonists. The key thing to bear in mind with the Stefan Leut network meta-analysis, however, is that as part of their exclusion criteria for the meta-analysis, they excluded patients with predominant negative symptoms. And so they were looking at changes in negative symptoms in patients who didn't necessarily have that high burden of negative symptoms. And it's very easy to see an improvement in negative symptoms if you've helped someone with positive symptoms. What do I mean by that? Well, if you're paranoid, you don't want to leave the house. You're sort of getting a secondary negative symptom as a consequence of that. If your paranoia improves and you leave the house because you're no longer paranoid, are you truly fixing someone's true negative symptoms? I would argue you're not. So yes, there is an evidence base for partial agonists. I would argue aripiprazole, but as I said before, the only clinical trial that are available doesn't mean there aren't. The absence of evidence doesn't mean absence of effect. But the only actual clinical trial that we have available where a company has decided to pick their drug head-to-head with another, standard, commonly prescribed antipsychotic is cariprazine versus risperidone, which shows superiority over risperidone. But yeah, aripiprazole can be effective in trying. Because I know that cariprazine isn't necessarily available at the moment.
Says, Dr. Pillinger, I really appreciate your talk. It is great and very relevant to our practice. My question is, there is this idea that compared to olanzapine, risperidone, and quetiapine, partial agonists don't work or aren't at least as good. Also, is Thymatic validated for use in elderly? So basically saying, are they effective as the risperidone and olanzapine?
It's a really interesting question. I think so. The quick answer to it: so validated use in elderly. So the data is based on adults. General is adult patients. So working age patients with a mean age of 40. So you may need to extrapolate to older adults. But yeah, as we've shown in children, adolescents, the side effect profiles or the relative risk of across agents is similar in that population. You would expect it to be similar in older adults, although of course, as you know, you always have to be cautious about elderly patients being super sensitive to various side effects. But I would argue, although it's not using older adult data, it's probably as close as you're going to get in terms of the database to providing that information. Efficacy, what we know, again, going back to that Stefan Lloyd paper, is that there does seem to be some differences on average across the various treatments when it comes to antipsychotic efficacy. I think the important take-home message for me when I have these discussions, certainly in early intervention or the first steps of psychosis services, is that all of these treatments that we have licensed are effective antipsychotics. They are effective in clinical trials. You would argue, of course, so maybe some antipsychotics on average are more effective. But the problem is we're not all built the same. So I would argue we don't know which treatments are going to be more effective in some cases than others. And I think certainly when you're trying to prescribe an agent first line, for example, I find it hard to be, personally, I find it hard to be in a position where I could justify using an agent like olanzapine first line, bearing in mind the side effect profile that it has. Of course, there are caveats to this in the context. I'm saying in this scenario, I'm saying we're in an outpatient setting where the burden of illness is not so far high as that someone's ended up in hospital. I understand the rationale for use of medication like olanzapine, context of using it sort of in a rapid tranquilization of issues in the short term. But I think broadly speaking, if you've got broad control over symptoms in first episode basis, I find it hard to justify why you wouldn't use an agent such as a partial agonist first line. Recognizing that, okay, well, maybe it won't be effective in everyone, but that goes for any antipsychotic. So the people who don't respond to olanzapine or people who don't respond to clozapine. But I think if we use, certainly speaking from personal experience in the nausea, I think we use treatments such as patients are coming out of the wards on olanzapine. And it takes 3 or 4 months for them to have a medical review with a psychiatrist. By then, 10 kilos of weight's gone on. The patients stop the treatment on their own because they hate it, and because why would they want to take it? Because it's causing so many side effects. You end up shooting yourself in the foot because rather than giving a patient a good opportunity to get better with an effective treatment with a lower side effect profile, they've ended up, stopping the treatment off their own back anyway because they hate it. So it's a rather waffly, long-winded way of recognising that there are different treatments that maybe, have different efficacy profiles according to clinical trial data. But I think these are all effective treatments on average, based on clinical trial data. And I think, again, the litmus test of what would I like to be treated with, given if I have first episode psychosis, or what would I want my sister to be treated with, I would, and again, this may differ from individual to individual, but I would argue I would prefer to prescribe arrogance first. There had actually been surveys done of practitioners. I mean, it's going back several 10 years. I think Samir Johar ran this across Europe, and aripiprazole was the #1 treatment that practitioners would want to be prescribed to themselves if and this is going back to there was no partial agonists out there. It was what they would want to be prescribed. And you give yourself that things to get faster on a thing with a low side. Sense.
the last slide that cariprazine is superior to other second-generation antipsychotics currently available. Do you have personal experience in prescribing this molecule for patients switching, and does it show a significant improvement?
Yeah, so I'm not quite sure which slide you're talking about, but I mean, broadly speaking, I've used cariprazine when I was, so I work in liaison psychiatry these days, and so my working in, but when I was last working in a field of purely looking after people with psychosis, I very much had my hands tied by what the trust would allow me to, the context of how I was able to prescribe cariprazine. And at that time, cariprazine was only available for us in the context of treating predominant negative symptoms. And so I've given to do a SANS, an assessment of negative symptoms ahead of prescribing it and assess over time. And then there were all sorts of barriers to them discharging patients to find repair on cariprazine because they weren't willing to take that. Things have improved now, and I know that lots more people, these drug treatments are becoming more available and primary care and starting to take over that treatment if the more easily prescribed for at least a year or so. I've had a good experience of using cariprazine in context of negative symptoms, and I think it is a valuable addition to the to our armory of antipsychotics, which is when you bear in mind not much has changed. I mean, I know the field is changing a lot with the new tar agonists, muscarine, etc. But up until recently, we haven't really had much of a change in terms of available agents, and I think it has been a useful addition to our formula.
What is your view on preemptive initiation of metformin for non-diabetic schizophrenic patients to mitigate metabolic side effects such as weight gain?
Yeah, such a great question. I think the quick answer is, so in first episode psychosis, it can be hard enough giving someone one tablet, let alone two. Especially bearing in mind that metformin can have gastrointestinal side effects. They're very big tablets. So that caveat aside, I think no one's done the study that definitively shows whether giving metformin alongside an antipsychotic in someone who's antipsychotic naive can mitigate to an extent the metabolic side effects. That said, there is now robust data from Dan Siskind in Australia, which shows that if you give metformin alongside clozapine, then you can really go a long way. In people who aren't overweight, who don't have diabetes, you can go a long way to mitigating and attenuating weight gain associated with clozapine. To the extent that in Dan's clinic in Australia, and he gives a lot of people clozapine, metformin is given as routine with clozapine from day one. Up titrates just 2 grams. Now, the key question is whether we should be starting to broaden this to other antipsychotics, and we don't have the data yet to support them. But certainly, if someone's pre-diabetic or already overweight, I think there is an argument for, and you're thinking of clozapine certainly, or olanzapine, then I think certainly metformin is appropriate there. But I don't think we at the stage, well, we're not at the stage yet where we have the data to support if you've got someone with a BMI of 22 who you're starting aripiprazole, for example, should we be giving them metformin as well? We don't have the data to support that at the moment. But it would be an interesting project to do and look in early intervention and see across groups whether proactive rather than reactive metformin use would be helpful.
The time is pressing on. One or two final questions. This is from James Briscoe, an early intervention consultant here in Stafford. As a clinician, which side effects would you most want your patients to avoid? Tardive dyskinesia, weight gain, prolonged QTC, akathisia, regardless of what their preference might be?
Oh, golly, I think that's an impossible question to ask, because I think by virtue, these are side effects that will have different importance to different individuals, and I don't think I can answer that. I think because we recognise these different side effects can have devastating consequences to everyone. Akathisia can drive people to suicide, for example. Tardive dyskinesia can be so disabling based on if it's very severe. The weight gain can lead to a heart attack or a stroke. So I think I wouldn't wish any of those side effects on anyone, and I think addressing them pragmatically, recognizing different pharmacology of treatments, we can only do our best, and we try and avoid all of them. Thankfully, the rates of TD, for example, now that we don't use such heroic doses of antipsychotics, the rates of TD are always much lower than they used to be. Of course, now the weight gain is something that we're addressing now. I think we're getting better, and I think what's nice is that I think we now have data to support this process for us to be more physiologically prescribing, and so hopefully we will avoid all side effects to the best of our ability, like this, rather than being one of them.
Last question: presumably better for patients with negative symptoms. What about the side effect profile compared to other antipsychotics?
Yeah, it's got evidence for being effective in negative symptoms. I mean, it's important to recognise it's an effective antipsychotic across the board. I mean, it's effective for positive symptoms as well. It just so happens that there's evidence that it might be even more effective in negative symptoms. I mean, akathisia is the one that's the sort of the main one that I've noticed that has emerged in the case of prescribed with a dose reduction can be effective in eliminating that. But it's generally, and again, in this my clinical experience, has been a well-tolerated treatment. With like I said, thinking back to that McCutcheon paper I showed you before, in terms of the clusters of antipsychotics, the 4 clusters with the partial agonists in one, and you look across all of the side effects for that cluster, it's relatively low side effect burden across all of the different side effect domains. That doesn't mean that one individual won't be more vulnerable to side effects. Generally speaking, it's quite a well-tolerated side effect, which is why we like the partial agonists as a first-line agent.
Time has pressed on. I'm going to now take moderator prerogative. Nearly 470 people are still online, Dr. Pillinger. Please tell these people the 3-4 take-home messages on this wonderful webinar this evening, please.
Okay. Well, first of all, thank you everyone for tuning in. It's really lovely to talk to you all. But I think if there are 3 main things that 3 key take-homes. So I think number 1 is, I think you know these things already. Side effects are common. Side effects of antipsychotics are common. But what's important to recognise is that they are of primary importance to our patients. And so, in that context, they really should be of primary importance to us, which I know they are. So that's number 1. Number 2, I think, we have good data now that shows us that not all antipsychotics are built the same. They are pharmacologically distinct. They have overlapping, of course, receptor binding profiles, but they have a distinct pharmacology, and it should therefore, in that context, be possible to be pharmacologically minded in terms of choosing appropriate antipsychotics given concerns about side effects or efficacy. So that's number 2. And then finally, number 3, we've got this wonderful digital tool called Cymatic, which is available for everyone to use, freely available to use, which to facilitate that antipsychotic prescribing process and antidepressant prescribing process. It should facilitate evidence-based and personalised prescribing, and I encourage everyone to at least give it a go in their day-to-day clinical practice.
Dr. Pillinger, thank you very much indeed. And the next slide, please. Please do complete the feedback survey. Due to the license indication for cariprazine, schizophrenia in adult patients, we can only conduct meetings within this license indication. For more information on cariprazine, please do visit our website, www.reagila.co.uk. Next slide, please. Please do join us for Webinar 2, Series 9, Wednesday, the 22nd of November, between 5 and 7 p.m. The role for D3 receptors in dual disorder schizophrenia. And our guest speaker will be Professor Stefan Hjorth, Professor in Pharmacology and an independent pharmacological consultant. Finally, a huge thanks to our guest speaker, Dr. Toby Pillinger. We look forward to welcoming you back. Many thanks to Russell for all the technical support behind the scenes. Above all, thank you to all you 450 people still online attending our webinar 1 of Series 9. Please do complete the survey, which will follow soon after the close of the webinar. Finally, the certificates will be with you all very soon. Please do enjoy the rest of this evening, even though it's a wee bit wet. We look forward to welcoming you all next month, 22nd of November, enroll for D3 receptors in dual disorder schizophrenia. Enjoy the rest of your evening. Keep well and keep safe. Thank you. Buonasera and arrivederci from Record Data UK. Thank you. Thank you.